My name is Christina Monnier, and the date is April 29th, 2024. So in this presentation, I'm going to be talking about Gaucher disease, which is a lysosomal storage disease caused by a wide variety of mutations to the GBA1 gene. Just setting the scene, some signs and symptoms that people will experience. The disease is pretty complex and highly individualized, although there are 3 identified types. The first of which is the most common and often least severe. In type 1, most people will live with some initial symptoms for a couple of years until medical providers are able to finally arrive at the Gaucher diagnosis. For all 3 types, people can experience any of the symptoms that are known to be associated with bones, blood, and organs. I'm just going to list some things off, but this list is non-exhaustive. Some common ones are fatigue, generalized malaise, an enlarged spleen or liver, an accumulation of glucocerebroside enzyme in the lungs. So from here on out, I will refer to that enzyme as GCase. Difficulty clotting when bleeding, frequent nosebleeds, intense bone pain, interruptions in bone remodeling due to the lack of oxygen getting to the bone tissue, which poses some problems with bone repair, obviously, and then also with bone development as people are growing. Spontaneous fractures, osteoporosis, arthritis, joint pain, and the list kind of goes on. People with any of the 3 types of Gaucher also have a higher risk of developing blood or liver cancers and also Parkinson's. People with types 2 and 3 are the ones who will experience the neurological symptoms, and these usually show up at a pretty young age, sometimes as early as 6 months. Type 2 is particularly progressive and has a very poor prognosis. Some of the notable neurological symptoms include poor delayed development, difficulty swallowing, seizures, and spasticity. And it's the complications of these symptoms that are what lead to death in people with types 2 and 3. So the cause of all this can be traced back to one of around 300 or more mutations to the GBA1 gene. The GBA1 gene encodes for the GCase enzyme in macrophages that accumulate in bone marrow, in the liver, and in the spleen. So looking at this detailed schematic, we can see a very generalized overview of what might happen in a Gaucher cell. We can look over to the rough endoplasmic reticulum and see that there is an unfolded protein response, or a UPR, that is triggered by misfolded GCase enzymes in the ER. And this is an adaptive mechanism, but after prolonged activation of the UPR, reactive oxygen species are produced and create oxidative stress and downstream inflammation. So the decreased GCase activity then leads to mitochondrial dysfunction and a buildup of glycosphingolipids in the lysosomes of the macrophages. And the macrophages are known to have a lot of lysosomes also. So the GBA mutations are less associated with cell cycle checkpoint failures and more associated with metabolic function or malfunction, putting Gaucher in the category of lysosomal storage diseases. So just in summary, the lysosomes of a Gaucher cell will progressively swell with undigested glycosphingolipids, whose digestion is normally catalyzed by the GCase enzyme. This accumulation causes widespread inflammation, starting at the organelle level, as we saw in the previous slide, and all the way up to the organ and eventually organism level. In some severe cases, the liver has been found to enlarge around 3 times its normal size, and the spleen around 15 times its normal size. Who can get Gaucher and how? So Gaucher inheritance follows an autosomal recessive pattern. This means that an individual must inherit 2 copies of the defective gene, one from each parent, in order to develop the disease. If someone has 1 copy, they will not develop the disease, but they will become a carrier, and they can pass the gene on to their children. So if 2 carriers mate, there is a 25% chance with each child that they will inherit both copies and develop Gaucher disease. There's a 50% chance that with each child that they will become a carrier, and then a 25% chance that with each child, no copies of the mutated gene will be passed on. They'll just get normal genes. So this illustrates the benefits of performing genetic testing. When someone knows they are a carrier and they want to begin reproducing, it's advisable that their sexual partner be tested for the gene. It's also a good idea to test for the gene if someone knows that one or both parents are carriers, since for some people, symptoms may be so mild that they wouldn't think to seek treatment for them until the disease has progressed. So becoming aware as soon as possible is really beneficial. It's also to someone's benefit to know whether or not they are a carrier in case they decide to reproduce. Right now, there is only one known population to be overrepresented in Gaucher disease rates, and that is the Ashkenazi Jewish population. Among the general population, researchers have found a range of incidence rates, anywhere between 1 in 40,000 people up to 1 in 100,000 people of the general population will be diagnosed. The rate is remarkably different for Ashkenazi Jews. So 1 in every 800 people are diagnosed with Gaucher, and 1 in every 10 people are identified as carriers. At this point, researchers don't really know why, and why the Ashkenazi Jewish population are overrepresented. The epigenetic factors involved are still up for debate and under-researched from what I could see. And while researchers know that environmental and lifestyle factors can worsen symptoms and hasten the progression, there's still very little epigenetic understanding and research. Since the disease can cause a widespread constellation of symptoms or mild to no symptoms at all, it often goes undiagnosed until a couple of years after the first onset of symptoms. And this is for, speaking specifically to type 1. In types 2 and 3, the symptoms do become severe enough that a lot of testing will then eventually lead to the diagnosis quicker. GBA1 mutation testing is not a part of routine health examinations, so testing for this disease is often the last stop, and again, especially for type 1. In the process of seeking treatment for a series of misdiagnoses, people undergo unnecessary and invasive bone marrow or liver testing and treatments before actually getting a proper diagnosis. And this is unfortunate because testing for the illness can actually be performed with a simple blood test. And this test measures, you can see the measurements of the GBA1 enzyme, or you can detect the mutant GBA1 alleles. So in the enzyme test, doctors look for the enzyme levels in cultured fibroblasts or in mononuclear cells or leukocytes. Deficiency is what will indicate the presence of the mutation. Often there is approximately 10 to 15% of normal GCase enzyme values in people with the GBA1 mutation. In addition to a diagnosis, the testing can be helpful for a prognosis, because while the disease is so individualized and largely unpredictable, there are some mutations known to be associated with the development of certain symptoms. Genetic analysis can also be performed in utero using the amniotic fluid cells or the chorionic villus. While there is no known prevention for the mutation itself, treatment can slow or prevent symptoms and the damage caused by the disease when it's left untreated. And again, speaking mostly to type 1, in types 2 and 3, there aren't a lot of treatments right now for the neurological symptoms. The 2 widely verified and used treatments right now include enzyme replacement therapy, so ERT, and substrate reduction therapy, SRT. So in ERT works to balance low levels of GCase enzyme with a modified version of that enzyme, and that's administered biweekly or once a month via IV infusions. SRT works to reduce the amount of GCase enzyme produced by the body, and this is a daily oral medication. And this is just an image of a young kid before and after, so you can tell that some time has elapsed between the first image and the second. You can tell that his organs are swollen, and after ERT, he looks from the outside relatively normal. So because misdiagnosis and underdiagnosis are both unfortunately so common, there are some efforts being made to create new tools to help point medical providers in the right direction sooner. For instance, a team in Italy hypothesized a use of a diagnostic algorithm alongside other routine and cheap tests that people would normally get in a doctor's visit. And after their sort of scattered site research project, they have concluded that their equation sort of works to help predict the probability of the mutation. And as far as clinical research or the treatment research goes, there are a handful of ongoing clinical trials. So one popular area of study focuses on the development of daily oral ERT, since IV, for obvious reasons, isn't ideal for everyone. In 2015, researchers were able to confirm that patients who had been on IV for a while could safely switch from that treatment to daily oral. And since then, there's been some more research developing drugs that will work for people, and elaglustat is an oral ERT that is under current investigation, and it has started to gain more and more approval internationally. At Royal Manchester Children's Hospital, there's a doctor who is in phase 1 of studying a genetically therapeutic drug that would target specifically the neurological symptoms of type 2 Gaucher. And then there's a doctor at University of California, San Francisco, who is in the recruiting phase for her study that will look at the safety and efficacy of in utero ERT. So interesting stuff happening. Seems like the frontier is looking at neurological symptom treatment, gene therapy, possibly in utero therapy, and then hopefully in the future some more epigenetic research. So thanks.